lytic areas are seen involving the visualized bones. These are involving bilateral femur and pubic rami, iliac bones. There is also sclerosis of bilateral SI joints, more pronounced on left side. I'm looking for any pathological fracture, which I don't appreciate any displaced pathological fracture. However, there is slight sclerotic line can be seen along the neck of the left femur, which is suspicious for any impacted fracture of left femur, and also some degenerative changes also noted along the
Okay,
visualized
so what are
lower.
you like? What is the principal finding
Um,
in these images?
Basically, the lytic lesions, which are diffusely involving the visualized bones. So I'm suspecting these could represent metastatic, maybe multiple myeloma, one of the differential.
Do you want to see the other images also?
Yes.
So you can actually, do you have control? One second, I'll give
No,
you control.
okay.
Wait. Yeah, I think you have control now, right?
Okay.
Yeah.
Okay, this is a lateral radiograph of skull of the same patient, in which I can appreciate small lucent lesions involving the skull. They're scattered in the skull. However, the density of the skull bone appear normal to me, and these lucent lesions are also seen involving the uh, visualized ramus of the mandible as well. However, cervical spine is not, I can't appreciate these lesions in the cervical spine. Maybe this is not the projection to comment on the spine. I would look at the further use of the provided limbs. I can appreciate these lucencies involving the humerus as well as scapula, and there is also erosion of the visualized ribs. So, considering these appearance of this lesion, and there is involvement of axial as appendicular skeletal, I'm suspecting these to be lesions of the multiple myeloma.
Okay, so what will you do next?
I would inform the primary physician about this condition and then refer the patient to the uh, MDT and further workup with
Sorry,
CT
I didn't
scan
get
check.
that part. You will do or what will you do first?
First, I'll inform the referring physician, primary
Okay.
physician who referred this patient, and then further workup is suggested with CT chest, abdomen, pelvis.
CT chest, abdomen, pelvis. What are you expecting?
To look for the extent of the disease, and bone scan is also suggested. That
How
CT
does
chest, abdomen,
multiple myeloma appear on bone scan?
it will appear, it will be cold lesions. It will not show uptake because of the
Any
lytic
other
areas.
modality is there which can help stage multiple, I mean, categorize the burden of the disease in multiple myeloma?
Uh, mm,
Like suppose
Maybe.
considering the fact that this is a case of multiple myeloma, what I'm saying is that suppose this is a follow-up case and you have some previous images, whatever it is, and you want to compare the present disease burden with the previous burden. So what are the one or two modalities which you can think of which will help you in that regard?
And for comparison, maybe, we can, if we have cross-sectional images, CT scan can help if the patient already have that CT scan.
Yeah,
Then the
no, no.
bone
I'm what
lesions,
I'm
yeah.
saying is that you, if you, I'm suggesting that your diagnosis is probably correct. But what I'm saying is, what is the modality of choice to evaluate the disease burden? How do we evaluate the disease burden in case of a patient with multiple myeloma normally in a cancer setup?
I'm not sure about that.
Okay,
Maybe
fine.
because
What is the
yeah.
how will you differentiate multiple myeloma versus metastasis?
By the CT scan, we will know that there is no underlying
No,
primary.
on this, on
Then
the X-ray, I'm saying
on the on the radiographs,
on
because
the
the
present
diffuse,
images, on the present
yeah,
images.
the lytic lesions and the diffuse involvement basically is the more in
Anything
favor of.
about the size or the anything about the size or the sites of involvement which you have seen in the present images? Do they have any? Do they give you a clue about it?
That's what I'm saying. This diffuse involvement and the size is, these are very lytic lesions are very small in size, and they're in
Any
compared to
particular
mets.
site? Any particular site? Okay, we'll go to the
Um,
next. Okay, you can
okay.
answer that, no problem. I'm just going to the next case.
Particular site, I'm not sure about that.
Okay, fine. This is the next case. There is no history.
Okay.
Okay. You cannot see the lateral. Okay, you have to comment on the frontal only.
Okay. Can you zoom a bit, because this image is
I'm
very
not
small for me.
sure about that part. I mean, I can try.
Just zoom the yeah, Chrome.
Yeah. One second. Is it working? I don't know.
Yeah, this yeah. Here, 100%. You have to increase it. 100%.
Acha, okay. This one.
Yeah. I hope it. It's
Oh
getting
my God.
more smaller.
Yeah. It
Okay.
is becoming weird. I think this is optimum.
It's the other way around. I think you have to
I have to decrease it, right?
decrease it. Yeah.
Okay. Wait. Right. He's right. Fine.
Yeah.
Okay. Can you see it now?
Okay. Yeah. So I'm provided with the right hand radiograph of adult patient, slightly mature
Okay.
patient.
I will give you a history because I'm trying to simulate the actual exam scenario as much as I can. So the history is the patient is a sports person who has recently come with an injury to the ER, and you're presented with this image. The ER has referred the patient for an X-ray, and you're the radiologist on duty.
Okay. So I'm looking at the radiograph of adult patient who presented in ER with the history of sports injury. Bone density appear normal to me by looking at the now systemically looking at the carpal bones. There appear to be slightly increased gap between the scaphoid and the lunate. Um,
Okay.
However, the intercarpal joint spaces appear intact, and carpo-metacarpal joint spaces appear normal. Visualized
Mm,
bones not showing any displaced fracture.
okay. Carry on. So, like, what are you suspecting? What is your thinking process right now? Hello? Can you hear me? Hello? Hello?
I think we lost Dr. Yusuf.
Oh, okay. Is she there?
Can you hear me?
Yeah, I can hear you. I can hear you. Were you able
Yes.
to get my question, or should I repeat it?
Please repeat it. I didn't hear you.
Yeah, I just said, like, what is your thinking process right now? What are you trying to rule out one by one?
Yeah. So I was ruling out first. I was ruling out any arthritic changes and any fracture, because since patient present in ER, so fracture was my first
Patient has
priority to
come with
rule
a
out.
sports injury. So, I mean, you don't have to rule out arthritic changes in this. Hello?
There is increased gap between the
Okay.
unit and the scaphoid.
Okay.
So I am suspecting a scapholunate dissociation.
So what is the expected gap between the scaphoid and the lunate to call it a scapholunate dislocation? What is there
It
any
should
cutoff?
Greater than 3 mm, I think.
Yeah, 4 mm is safer. Do you think this is more than 4 mm? Yeah, there is a gap, I admit that. Anything else you can think of?
Um, Otherwise, mm,
Okay, so what will you do in your usual practice?
in my usual practice, I would review the other view of the radiograph and
Okay,
then.
you can see the before you go to the other view, anything about the carpal arcs you like to comment on?
Okay, there is a slightly gap because of that. The inferior carpal arc is okay, but in the upper part, I think there's slight increase overlap between the
Is the arc okay?
triquetrum. The distal arc slightly looks disturbed to me in this projection.
Okay, you can see the lateral projection. I think you have control. You have control, right? Or should I click it
Yeah,
for
yeah.
you?
Yeah,
Okay.
click it. I think I'm unable to click it.
Okay, fine.
Okay. So on this provided lateral view, which is slightly oblique, in which I can appreciate there is slight rotation of the lunate, and the carpal bones are dorsally displaced. So I'm suspecting perilunate dislocation
What will
in
you
this
do
patient.
next?
Orthopedic referral in this urgent orthopedic referral in this patient, and communicate my findings to the ER physicians.
So, suppose this patient had come to you in the not to you to the GP in the in the emergency, and the GP had shown it to the orthopedician, and before you could report the radiograph, the orthopedician put the patient in a splint and temporarily discharge the patient. In that case, what will you do?
Uh, I would inform the general physician about the report, and then and I'll also offer them to arrange for MRI to look for any ligamentous injury in this case.
No, yeah, I get that part. I am saying suppose the patient has been let off for the time being by the orthopedician in a splint. In that situation, what will you do?
Um, I'll inform them about the derangement because there is, but I'm not aware of the management though. I'll tell them that this is
Okay.
the report, yeah, report of the
So
patient.
will you ask the patient to follow up on a subsequent day, or what? I mean, what I'm trying to basically ask you is that how what kind of a gap are we looking at here? Will you seek an immediate referral, or do you think that it's okay that the patient has been left in a splint and he can come
Uh,
back after a certain period of time?
no, I will seek an emergency referral. So,
Okay. So I
yeah.
think there is an MRI also, though this was maybe it is not necessary, but since it is there, you can comment on it.
Okay, so this is MRI sagittal image in which there is the X-ray findings are confirmed, and there is a perilunate dislocation with carpal bones are displaced uh, dorsally, and the lunate is partially maintaining its surface with the articulating surface of the radius, and these are just static images, right?
Yeah, I think that's okay. I think this is just extra. We'll go to the next case for you. Painless swelling, and you have an ultrasound. I think these are also static images. So you can already see what is the
Okay.
pathology. I want you to just describe it for me.
Okay, so this is ultrasound of one of the testes, in which I can appreciate there is a well-defined, rounded, hypoechoic area involving the testis, which is showing slight posterior shadowing, and there is very well-defined slightly hypoechoic rim in this, and there are some A hyperechoic area is also seen within it, and rest of the testicular parenchyma appear normal. I don't see any calcification. Minimal thickening of the scrotal wall can be seen, and partially visualized epidermis head is noted. I would like to see the images which are showing any vascularity in this.
I'm not sure if Doppler was taken. Yeah, okay.
Okay, there is no significant vascularity noted within this lesion, and there is minimal vessels can be seen in the periphery. However, within the center of the lesion, there is no
So what are your DDs?
vascularity, and there is no lesional. What is the age of the patient?
Maybe a young or a middle-aged patient, or maybe the age is unknown to you.
Okay, this may represent any burnout lesion.
What kind of a burnout lesion?
Burnout seminoma or burnout other germ cell
How
tumor
does a seminoma look
maybe.
normally on an ultrasound?
Uh, it took a heterogeneous lesion with maybe some ill-defined margins, but in the case of
How are the
burnout,
margins of this lesion?
they are very well defined.
Yes.
Sorry to interrupt, Sayan. 15 minutes are over. So
How much time do I have with her? 30 minutes, right?
as you like, 15 minutes or 30 minutes, or you want to finish the
No,
cases.
no,
It's up to you.
Yeah, I think 5 cases per person. I'll finish the cases. That way it is better, I think. Yeah.
Okay.
Yeah, carry on, doctor. Yes.
Yeah, so in case of burnout tumors, the tumor become more organized, so margins can be well defined.
Okay, fine.
But
Maybe. What are the more common possibilities?
it can be this is a lesion basically. So if
This
the
is a
patient
sorry, I didn't get that part.
lesion. So basically mass.
Lesion. Yeah, it is
Yeah,
a lesion. Yeah.
yeah. So but the well-defined margins are keeping with non-aggressive nature
Right.
of the lesion. So in the case if patient is not symptomatic, then follow-up
No,
or
I mean,
prior
when you're saying the word lesion, what do you mean by that?
I'm saying it's not an infection or it's not other kind of process like inflammatory or something.
Okay, fine. I agree with you. It is not an infective thing. That's true. So what are the
Yeah.
DDs?
So differential could include seminoma or other germ cell tumor.
But you said just now it's a non-aggressive looking entity, right?
Yeah, but then burnout tumors are
Yeah,
non-aggressive.
you can ignore. I mean, yeah, maybe that will be later in your list of differentials. What are the other more likely possibilities?
Other possibilities in a testicular lesion.
Suppose it is just an incidental detection. The patient is not having that many complaints and all.
Less likely reti testes also, but the reti testes usually have that
No,
cystic
okay,
appearance.
exactly. This is not ready testis.
Yeah, that is.
Okay, so
Yeah,
what will you?
so that's why
So
I'm not
fine.
putting in that.
Let's forget about that. So what will you do? Whatever you just suggested are the possibilities. How will you come to a definitive conclusion? Since you're suggesting, since you're
I
thinking
would
this may
refer
be an
this
aggressive process.
Yeah, since patient is not having in pain, and though a follow-up ultrasound may be done in few weeks' time to look at the size of this lesion, and if there is increase in size or increase in pain, then we might suggest any biopsy of this lesion.
So testicular biopsy is a very painful process. Is there any other way you can come to a conclusion without sampling this?
Uh, uh, MRI may be helpful in that case. Scrotal MRIs are
Anything
usually
other
now
than
done
imaging, other than radiology?
other than radiology. Maybe I would refer this patient to urology for examination, but how would
No, no.
I'm
What
not
I'm
sure
trying
if
to
that
say,
would
any
have.
other markers are there apart from imaging?
Okay, HSG can be done, and
Basically, serum markers,
embryonic
right?
markers. Yeah, embryonic markers can be done.
Is the most common marker that we see when we are seeing germ cell tumors.
Um, HSG can be done with that.
HSG. Okay, fine. We'll go to the next case. There is a patient with shortness of breath, 50-year-old patient.
Okay, so I'm present with frontal radiograph chest of adult female patient, in which I can appreciate there is a fairly well-defined opacity involving the right paratracheal region, with the margins of the lateral margin of the lesion are well-defined, and however the medial margin is inseparable from the adjacent mediastinal structures, and it can be seen extending above the clavicle, and subtle
Yes,
lucency can be seen along its upper margin, and there is a slight mass effect over adjacent trachea. However, no abnormal calcification,
right.
lucencies, and cavitation noted within this lesion. Uh, and since an upper neck is not covered, so a possibility of this can be extending from the neck cannot be entirely excluded on this current projection. So either this
So
can
what
be
are
in
your
the posterior.
DDs?
So this can be a posterior mediastinal mass, or mass extending from neck. Could be a neurogenic tumor or a thyroid mass. Other
So
possibility. Oh,
yes, that's absolutely right. So what are the ancillary features if it is a posterior mediastinal lesion? What else will you look for?
it could be maybe rib erosions can be there. Some vertebral body
Yes,
erosions
right.
can
So
be
can you see
there,
any of
and
those things
since
here?
this ribs look okay, when the anterior end of the clavicle, medial end of the clavicle look okay in
Okay,
these
fine.
projection.
So, okay,
Yeah.
I get you. Yeah. So what will you do next?
In this case, if I can offer the MRI of the patient to look for the
MRI.
lesion. Yeah, if the posterior mediastinal lesion, so I'm suspecting
Why
neurogenicity.
MRI?
So, for posterior mediastinal lesion, neurogenic tumors,
But you
I
just
would.
now said there is no ancillary feature, right? Supporting a posterior mediastinal lesion.
But it's yeah.
What was your other
CT scan.
differential?
Other differential was a neck mass. Could be extending from the
Yeah.
neck.
So what can you do to see whether it is a neck mass or not? What is the easiest
Maybe
invest?
CT scan.
Even
Uh,
easier than a CT scan.
ultrasound can help.
Yes. Okay. So I think this patient had a CT scan, but ideally, as you said, ultrasound should be first. So if you don't have control, I'll just give it back to you. A
Can you
second.
scroll, because it will be very
Okay.
slow if I'll scroll. Yeah.
Okay. Okay. But in real exam also it will be slow only. So you have to
Okay.
get adjusted to that. Okay, I will scroll for you.
കിട്ടിയോ ശ്യാമന് എടുക്കണ്ടേ ശ്യാമൻ ആദ്യം
Okay.
എടുക്കാം
Hello?
So this
Sorry,
is
there is some
CT
noise.
scan.
Okay.
I don't know. Maybe someone is unmuted.
Okay, okay, fine, fine. Carry on.
Okay. Can you go a little bit superiorly?
Yeah, I will just show you the full thing. Yeah.
So
Okay.
this is CT scan chest, neck, chest, and
What kind
in
of a
which
CT scan is it?
with contrast, CT scan chest with contrast.
Anything specific? Okay, let it be. Anyway, continue.
This is angiography because
It's
it
okay.
was
It's
written.
irrelevant to this case.
Yeah.
Right?
Yeah, so I can appreciate a lesion extending from the neck and into the mediastinum, and it is causing significant mass effect over the trachea, which is pushed towards left side, and it is inseparable from the adjacent esophagus, and it is showing slight density of a fluid, I suspect.
Where
However,
is
there
it
is several.
originating from?
Can you go superiorly, slightly superiorly?
Okay.
Yeah, now down.
Yeah. So where is it coming from?
Interiorly, it is slightly abutting the thyroid gland, but I am not sure if it's rising from the thyroid gland. But with esophagus, its margin is very indistinct.
No, first of all, is it a posterior? You still think is it a posterior mediastinal lesion, or you think it is coming from the neck?
It is running from the neck into the
Yes.
posterior
So
regions.
what is it
Yeah.
coming from?
So it could be coming from esophagus because the
From the
esophagus is
neck.
coming from. Yeah.
Okay.
From the neck.
More likely possibility, which you told in your X-ray itself.
Thyroid.
Yes.
Uh,
Yeah. Why
yeah,
not
with the
thyroid?
fluid.
I mean, you cannot see the right lobe, right?
Yeah, it's very indistinct, but I'm just confused about the density of the lesion because it looks slightly fluid to me in this way.
Yes.
Obviously, I
So
will
that
measure
was
it.
my next question. So if it is coming from the thyroid, and as you say, it's a fluid density kind of a thing, what is it?
Cystic nodules or that much large cystic nodule is slightly,
Okay.
maybe it's necrotic nodule or necrotic lesion. Other possibilities that.
Next case. This is your last case, okay?
Okay.
So it's an elderly patient who has come with a with diffuse body ache.
Okay. So I'm provided with bone scan, planar whole body planar images in a blood pool phase, in which on the initial images I can appreciate subtle uptake in the left side of the thorax, which is not demonstrating any or any correlating with any anatomical structure.
Can
It
you point
can
that out,
be
please? Can you point
yeah,
out what you're talking about?
this one. Yeah, this is
You,
can
you
you
have to
see my?
click on the screen first.
Okay.
Are you still having control? I think I should give you control first. Wait.
Yes, give me control. Yeah.
Yeah, 1 second. Yes, now you can point.
Yeah. So this uptake.
Yes, so you said it is not corroborating to any anatomical structure.
Structure, not bony structure. This could be in the soft tissues, maybe in the chest wall, maybe in the breast.
Okay.
And the yeah, and the posterior where there is no obvious any abnormal enhancement. The visualized bones normal uptake in the kidneys, SI joint, and bladder is appreciated. On the further images, I can appreciate some uptake in the sternum and the costochondral junctions.
Yes.
And there is increased uptake in the corresponding area. This could be uptake in the breast tissue. This is a female patient.
What are you thinking of?
Otherwise, this uptake in the breast could be any lesion because the contralateral
Like
side
what?
there is no uptake in
What lesion? What lesion?
maybe a neoplastic lesion or
Are there other DDs also for this?
uh, yeah, it could be a soft tissue. It could be in the chest wall. It could be a soft tissue lesion as well.
No,
And
I get the part that about the origin is not very. It's a bone scan. It's not a anatomical this thing image. But what I'm saying is that you said it can be neoplastic. So are there other possibilities other than neoplastic
yeah,
also?
infection, inflammatory. They also show uptake on the bone
Are there
scan.
any
Yeah.
other areas of uptake in the image that you just not described?
Maybe in the salivary tissues in the nasal
No, 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 no,
mucosa.
no, no. I mean the bones.
Bones, yeah. Scapula, bilateral symmetrical uptake, and there's also
You
faint
told
uptake
about
in
the
these.
sternum, right?
Yeah, and the
Yes.
costochondral
Yeah,
junctions on the right side.
yeah, no, that's fine. What I'm trying to say, suppose it was an infective or an inflammatory condition, can you explain the sternal uptake?
Sternal uptake. Um,
Okay, you can
Sternal,
see the delayed phase also.
yeah.
Yeah, tell me.
Okay, on the delayed phase, the previously shown the area of uptake is not showing any uptake on the delayed phase. And the delayed phase, there is the external uptake can be appreciated on the first two images, and for the delayed phase, the uptake in the manubrium appears slightly more prominent.
Okay, so
And
now
there
you
is
have to tell me what are your principal diagnosis and what is your topmost differential.
okay, so it could be is there any history of surgery, sternotomy, or something like that that could
No, I
also cause
mean,
some uptake?
even if it is
It
there,
could be
I'm not aware of it. No, the point. Yeah, okay,
external
fine.
uptake can be in the breast metastasis can cause uptake in the sternum as well.
So what will you do next?
I would correlate with patient's prior and further images, which was already done. If patient is already a known case of some
So if it's a new
primary
patient then.
malignancy, then mammography is suggested in this patient, and ultrasound correlation with
Mammography is
further
one investigation. Other than that,
ultrasound and CT scan chest, abdomen, pelvis to look
okay.
for
And
the
then what will you
primary.
do? Suppose there is a lesion in mammography or a mass in the mammography.
Then obviously first if this patient is coming primarily, then biopsy of that lesion
Hmm.
should
Then
be
next,
done. To next, this patient should be discussed in the MDT for further
which
management.
MDT?
Breast MDT,
Okay, fine.
breast
So
cancer
I think
MDT.
yeah, that was your last case. So I'll just go. Am I supposed to get the feedback now only, right? I think
Yes, I think.
Yes,
okay.
Dr.
Dr.
Sayan.
Sayan. Yeah.
Okay, fine. So yeah, Dr. Yasser, you're doing fine. What I think you should build on is you have to be a little more confident. Okay. I mean, what I feel is that you know the stuff, but you're hesitating a bit. So when I
Okay.
am saying that this case, the breast, you picked it up in the first co itself, it's a breast cancer with metastasis. There is nothing else to think about it because it is showing up in the blood pool and not in the delayed phase because that's a soft tissue lesion. So blood pool, blood flow and delayed phase. So the soft tissue takes uptake in the blood pool phase. And as you can see, as you yourself told, there are bone lesions also. So that basically kind of rules out the other possibilities. And when a breast mass is seen, as you said, first you'll do an ultrasound with a mammo. Mammo, you can see the lesion. Ultrasound, you further corroborate it. You look at the axilla, you look at the contralateral breast. If you see and something in the contralateral breast, that changes the staging. If you see something in the axilla, that changes the staging, and that axilla may need a sampling. Next thing you have to look at is are there any other lesions in the same breast or not on ultrasound? If you can see them on mammo, then also you have to corroborate an ultrasound. Next step is for primary diagnosis, you have to biopsy the primary lesion. And also, but this is a metastatic case. And if suppose it was not metastatic, to see the operability of the lesion, you have to sample the ipsilateral axilla to see whether it has spread to the axilla or not. Okay. And then the next thing that they will ask you, which they actually ask in the exam, is what kind of a gun you will use. You'll use a 16 gauge gun, and in the same breath you'll say that you'll refer it to the breast MDT. Okay, so that will finish the case in less than 2 minutes time, so that you will see more cases in that, because this is like a kind of case which you can save time on. That's what I feel. Okay.
Okay.
So this was your second last case. So this was basically, as you told yourself, that the DD was between a neck mass or a posterior mediastinal mass. As you correctly told in the X-ray itself, that this is a most likely a neck mass, because you told that the ancillary features of posterior mediastinal lesion are not there. So it was basically a goiter. So the fluid intensity was because probably of the colloidal material or stuff, and there was a focal area of calcification also.
Calcification. Yeah, I saw
Yeah, I
that.
will just try to show that if possible. Yeah, so this was basically a goiter. So the moment you say yourself it is arising from the neck, it is most likely a thyroid mass. You don't have to tell about the esophagus anymore. And the other thing is that thyroid, as you said, first is ultrasound, and I mean, if needed, they can do an FNSC or a biopsy from on ultrasound imaging only. And then, since it's a benign-looking thing, you probably don't need any further workup. You can just say it's a TIRADS 2 lesion. So you have to use these things like TIRADS or BIRADS, whatever. Though those are the American guidelines, but still you can use TIRADS probably, and it's a TIRADS 2. So anything which is TIRADS 2 does not need sampling normally. Okay, and even
Okay.
if you're suspicious, you can do an FNSC.
Okay.
Okay, So then comes your previous case. This was a pain. This was actually a bit surprising for me because I think you did really well in the other cases. I don't know why you went in a different direction on this one. This is actually a classic epidermoid cyst. Okay. There
Oh,
are
okay.
no DDs for this. It's absolutely an aunt mini. You cannot say a burnout tumor and all. They will get irritated if you say such things. Because this is an
Okay.
epidermoid cyst. It's a benign entity. Doesn't cause much of a problem. If the patient is still complaining, you go for a testis preserving surgery. And see it in a frozen section. You confirm it's epidermoid and tell the surgeon that's it. And yeah, if you do go around on the lines of seminoma and all, you have to tell about the serum alpha fetoprotein markers, those kind of things like ACG. You are saying HSG, it will be ACG probably. And alpha fetoprotein is the most common, which is seen in case of non-seminomatous tumors, but not raised in case of seminoma. But don't go on those lines at all in this case, okay? So the question they will ask
Okay.
you, what is this? You will say it's an epidermoid cyst. They will ask you, what is this appearance? This appearance is onion peel appearance. They will ask you if you're still not satisfied, what will you do? You can say you can do a sono ultrasound or this thing, fibroscan to see the how hard it is. And sometimes if it is still causing a problem, you can go for a testis preserving surgery. So that is controversial. It can be left alone also. So this was an epidermoid. Then this was your probably second case. So this was a perilunate dislocation, I think, but the thing is that you have to pick it up on the frontal. They won't give you the lateral in the exam. So you have to say something that the Gilula's arcs are not maintained. As you can see, the arcs should be absolutely proper. There should be no overlap between the proximal and the distal row. The moment you see
Okay.
an overlap, there has to be a carpal dislocation. And since it's a given history of a whatever sports person to say perilunate or lunate, that you cannot rule out on a frontal, that you have to say on lateral. And the next question that you answer correctly, that what fluid will immediately inform the finding to the clinician. And even if the patient has been left on screen, he has to be brought back because this is very notorious for causing median nerve injury and other complications. Okay. But the thing is that you have to pick it up on frontal if possible. If you cannot pick it up on frontal, you still see I'm tracing the Gilula's arcs, and I think they're not maintained. I'm suspecting a carpal dislocation, but since I'm not confident, I'll go for an orthogonal view. Okay.
Okay.
Now comes the first case, exertional dyspnea. This you did okay, but probably some of the things that you should know is multiple myeloma will be discrete, punched out small lesions, as you told. And the modality is not CT scan for disease, discussing disease load. What we do in normal practice is whole body MRI. Okay. You either do a whole body MRI or an FDG PET CT to see the disease burden. There is something called myeloma scoring. There is Oncorads, MyRads. You don't have to go that much deep. But if they ask you what is the modality, it is whole body MRI. Unless you do an FDG PET CT and then you compare the two, okay? The other thing is that how to rule out myeloma versus METs. One thing is size, other thing is the mandible. Mandible is involved in case of myeloma, as far as I remember. I also tend to forget this thing, but it's important for exam. Myeloma is involving the mandible and is spared by metastasis. And bone scan, I doubt how much useful it can be because as you yourself told, the myeloma usually is a cold entity, so it doesn't take up. So you cannot decide the burden on that. Other than that, this case was okay, I think. Okay.
Okay.
Dr. Yastrab, I think
Thank
this was your last case, right?
thank you.
Or the first
Thank you,
case, I
Dr.
mean, the
Sayan.
last of your 5 cases.
Yeah.
Okay, no problems. So who is the next candidate? Hello?
Hi,
Yes, hi.
this is Dr. Kashfa.
Dr.
Okay,
Kashfa is there, yeah.
Right. I think I will just 1 second. Dr. Kashfa, can you see my screen?
Yes, I can. So this is a 45-year-old male presenting with abdominal pain and diarrhea for 3 weeks, and there's a past history of inflammatory arthritis.
Right. Yes.
So I've been provided with the frontal projection of radiograph of the abdomen in a skeletal immature patient. I can see that there is a loss of the haustral pattern in the region of the transverse colon, the whole length of the transverse colon. I get an impression that there is diffuse thickening of the wall of the transverse colon. Apart from this, the rest of the bowel lobes, I don't see anything abnormal in them. I'm just giving a quick look to the bones. So the spine appears unremarkable. However, there is mild narrowing of the bilateral sacroiliac joint space.
Yes.
I don't see
What
any
are you
other.
thinking of?
So considering that the patient has a history of inflammatory arthritis and there is wall thickening of the transverse colon, so I feel that the pathology in the transverse colon is most likely.
Is it only in the transverse colon?
The descending colon is collapsed. So, but
I couldn't get you. Can you repeat that part again?
I said that the descending colon is collapsed, but retrospectively evaluating the distal half of the descending colon demonstrates similar features of loss of haustral pattern and wall thickening. So it seems to be there is possibly an inflammatory process, inflammatory colitis involving the transverse and the descending colon.
So what are your DDs?
So I'm thinking it could be related to ulcerative colitis because it has sort of a lead pipe kind of an appearance.
Okay.
It could be, it doesn't seem to be, it could be an ischemic pathology, but considering that the patient has a history of inflammatory arthritis, I'm thinking
Suppose
more
the
along
patient
the lines
did not have any history of inflammatory arthritis in that case.
In that case, it could be an ischemic etiology, an infectious etiology, or an inflammatory etiology causing colitis involving the transverse and the descending colon.
Can you, I mean, yeah, that's absolutely fine. So can you just tell me which is, ignoring the history of inflammatory arthritis, which is your topmost differential and why?
I would favor inflammatory colitis in comparison to ischemic because ischemic would more likely involve go according to a vascular territory, while this is involving the whole transverse and the descending colon. And I would normally, in my normal clinical practice, I would check
Anything
the
to do
serum
with the age of
markers.
the patient? How old do you think this patient is?
I was told in the history the patient is 45, and that's what his skeleton looks like. So it's a young patient.
In young patient, which one is more likely between ischemic versus inflammatory?
Inflammatory would be, I would suspect inflammatory more commonly.
Fall with head strike GCS score of 5.
Okay.
One second. I will just give you the control. Yeah.
Okay. So I'm just going to take a quick look through the
No problem.
images before I start commenting. So I've been provided with non-enhanced CT brain of a young male patient who has had history of falling down, presenting with a GCS of 5. And the most obvious finding is that I can see a biconcave high density area in the right temporoparietal region, which is predominantly hyperdense. However, it has few internal hypodense areas, raising the suspicion of ongoing bleeding. And this has the CT appearance of an epidural hematoma with ongoing bleeding. And there's mild contralateral mediastinal shift. There is effacement of the underlying sulci. There is also suggestion of possible impending uncal herniation. So in my normal clinical practice, I would pick up the phone and urgently inform the neurosurgical team on call, as this patient has subfall sign and impending right-sided uncal herniation and this epidural hematoma needs to be urgently evacuated. Evaluating the rest of the images for any other abnormalities related to the trauma, I can see I'm just evaluating if there are any other sorts of hemorrhages, for example, subarachnoid or subdural. I haven't been able to see any of that.
Fine. So what will you do after, I mean, in your usual practice, what will you do next?
In addition to informing the neurosurgical
In
team on
addition
call?
to in addition to informing the necessary person regarding your studying of the image, I'm saying.
I would look at the bone window to look for further fractures.
Okay. So what do you think is the management for this case?
The patient requires urgent evacuation of the epidural hematoma.
By craniotomy, probably.
Yeah.
Acute abdominal pain. Just 1 second. I'll just click on this here. You can scroll now.
Okay. So I've been provided with contrast enhanced CT scan of the abdomen. Images have been acquired in the portal venous phase. I'm just taking a quick look through the images before I start commenting. So the most obvious finding is I see a swirling pattern of the mesenteric vessels. This is associated with a markedly dilated loop of bowel. I'm just following the bowel to see exactly which part it is. So this dilated loop of bowel is a jejunal loop, yes, proximal jejunum. So there seems to be obstruction, and the bowel loops, small bowel loops distal to this dilated loop are collapsed.
Can you just focus on that particular point and then we can go ahead with the description?
Yeah, okay. I'll just go back.
Okay, fine. Now you can say.
Here, do you want me to stop here?
No, no, wherever you're comfortable. Means like when you're describing, you cannot scroll. That's why I'm saying you have to choose a point and then describe.
Okay. So here I can see that there is swirling of the mesenteric vessels and there is marked dilatation of the bowel loop, probably the proximal jejunum. And it seems like this is causing there is obstruction because the part of the small bowel distal to this dilated loop is collapsed.
No, you cannot use the mouse anymore. You have to stop scrolling. Okay.
Okay. So this imaging findings are suggesting closed loop obstruction.
Okay. What are the what is the reason behind that?
Because this could be because of a lax mesentery, which has caused, because of which there has been. No,
I mean what I'm trying to say is that what is the I mean, not the anatomical reasoning. I'm just saying, what is it? I mean, what is the closed loop obstruction due to in this particular case?
Volvulus.
Yes. Okay. Carry on.
So in my normal clinical practice, this person needs urgent intervention. So I would pick up the phone and I would inform the surgical team on call.
Okay, that is fine. So what are the complications that you will try to rule out?
I would want to look for any non-enhancing segments of bowel, to look for any ischemia.
Okay, one next.
Any signs of perforation.
Right. Right, that's it. I think those are the two most important things. And so how urgent do you think that this needs to be taken care of, or how fast will you take this up with the emergency physician?
This needs to be handled on a critically urgent basis, because if this continues, then there is chances of ischemia and eventually perforation.
Okay, fine. That's okay, I think. Okay. So can you see the history?
Yeah. So 30-year-old female with difficulty in conceiving.
Absolutely. You can scroll.
Okay. So I've been provided with targeted images of sterile salpingogram.
Okay.
The contrast is opacifying the uterine cavity as well as the bilateral fallopian tubes. The tubes seem to be patent, as evidenced by the presence of bilateral free spillage of contrast into the peritoneal cavity. However, the uterine cavity, it seems to be abnormal. There is a filling defect seen within the uterine cavity. It's sort of linear orientation. The filling defect has sort of a linear orientation. And I think there are a few more linear, there's a smaller filling defect inferior to that as well. So
Can you point those out, please?
Okay, can you see my arrow?
Yeah, I can see.
Okay, so this is the one that I'm talking about, this linear defect. And this, I think, is, these are the smaller ones.
So what do you think is happening?
Considering that they have a linear orientation, I'm thinking more along the lines of intrauterine adhesions representing Asherman syndrome, and less likely for it to be lesion, for example, a fibroid. So I'm thinking more along the lines of.
So what is the reason behind Asherman syndrome?
It could be either related to prior uterine procedures, or it could be related to prior infections.
What will you do next? What will you do next?
To differentiate these two, I would look for any pertinent history in this regard, and eventually to be followed up with an MRI of the pelvis.
Yeah, maybe, or you can just inform the gynecologist, that will be enough, I think.
Okay, so 50-year-old female with bilateral leg pain and past history of metastatic breast cancer. I've been provided with spot images of bone scan of a patient with history of metastatic breast cancer. So I can see a few well-rounded areas of increased uptake in the ribs, more obvious in the right-sided ribs. And there is also increased linear uptake in the bilateral tibial region. The joints are probably related to osteoarthritis. And so considering the history of bilateral lower limb pain, the linear orientation of the increased uptake in the bilateral tibial region could be representing hyperostosis. Hypertrophic periostitis. I think that was the name. Hypertrophic osteoarthropathy, that's, yeah. And HPOA. So in my normal clinic, and the ones in the ribs could be representing metastasis. So to differentiate whether
apart from the tibia, any other bones, you think? I mean, ribs are metastatic, that is fine. That's not a problem.
Actually, in the bilateral femora, I can see spot increased uptake along the lateral aspect in all images. It has a very sort of a uniform appearance, and it seems to be.
What do you think it is? What do you think they are?
They are cortical based, so they could also be metastases.
Other than that,
they're very bilateral and symmetrical. I'm not very sure what they could be.
Any other image you want to do to see what it is, what they are?
Yes, I would want to. In my normal practice, I'd look at the femoral radiographs.
To look at the, sorry, I didn't get that part.
X-ray of the femur to look at
X-ray, yeah, that's.
Okay, so I've been provided with X-rays of the bilateral femora, and I see that there is increased cortical thickening bilaterally.
Yes.
And again, it's bilateral symmetrical.
Absolutely.
It could be related to underlying osteoid-osteomas, which what I don't understand, what I find confusing about this.
Yeah, it can be, but they are symmetrical, and the patient is a case of breast cancer with multiple bone mets, as you yourself told. Do you think anything related to those things are coming to your mind?
Bone mets, stress fractures.
Yes, one possibility.
What else?
Okay.
Could be
Yeah.
I'm not
You want to
sure,
say
actually,
anything?
I'm not sure. I'm
Anything,
not
any
sure.
drug related things?
I was thinking maybe it could be related to the effects of therapy, like it could be
Effects of
stress.
which one?
Therapy, treatment, effects of treatment.
Yeah, so that's what I'm asking. Which treatment?
Chemotherapy, bisphosphonates.
Yeah, bisphosphonate. So that was your last case. I think you did pretty well. You mostly got all the diagnosis correct on your own without much help from my end. So one thing that I want to tell everyone is that the more the candidate speaks without letting the examiner speak, I mean, provided obviously that person is saying the correct thing, the higher the marks go up. It is kind of related to that. I mean, obviously, examiner will help you and will try to guide you in the proper way. But there is this thing that is, if you are getting too many clues, then your marks tend to drop a bit. That is how they mark it basically. So yeah, this was actually bisphosphonate related stress, bisphosphonate related fracture involving the femora, and the rest of things are fine. This is multiple mets are there, and the ribs and all. That is due to the breast cancer. The previous case, yeah, this was excellent. I mean, this will probably get an 8 or something, I think, because first of all, it's an HSG, which is in general difficult modality to pick up, and you diagnose Asherman's without any help from my end. That was a perfect answer. I don't have anything to say on this, because if I was given this case, I wouldn't have been able to say Asherman's in the first go. Then the previous case, yeah, this was also correct. This is volvulus. So you told everything properly. So the complications that you have to look at. And one more thing, this patient probably had a malrotation also. So that's okay. The main finding is the volvulus, as you told. For malrotation, you just have to see whether the vessels are properly oriented or not. Though they are, I mean, difficult to tell because there's all twisting and turning. But if you can just scroll through the images, maybe the large bowel loops are more predominant in the right side. I mean, the small bowel loops, sorry. So there is some, because I think the duodenum is not crossing over. Or the DJ junction, but that's okay. That is a secondary thing. Main thing is volvulus, and you have to tell about the emergencies and how fast you will inform the case to the clinician. Then your previous case, yeah, this was a descriptive case. So what I wanted you to do was pick up the uncal herniation, which you did correctly. So again, you'll get quite high marks on this, because the hematoma is obviously there. The other things, as I told you, is the one thing is the uncal herniation or any other herniation you have to see on, say, in a trauma case. You have to talk about midline shift, which you did. You have to talk about bone fractures, and you have to tell the examiner that you want to see the bone window, and then the examiner will show you the bone window in the real exam. So that is one more markable event for you. So the more number of images you see, as you probably know, those are all markable events. It doesn't depend on the number of cases you see. It all depends on the number of images you see or the number of modalities you see. Each modality or each fresh image is a markable event. You have to keep that in mind.
Okay.
That is how the real exam works. Okay. So this was also perfect. This was ulcerative colitis. So I just wanted you to tell the differentials which you told properly. Ulcerative colitis versus ischemic versus this thing, infective changes. And yeah, so the age younger patient inflammatory is more likely compared to ischemic, and this doesn't follow any vascular distribution as you told. So, and you also picked up the bilaterous ankylosing spondyle, I mean, the fused sacroiliac joints. So this was also fine. I think you did pretty well. I mean, I don't have much to change about what you're doing. I mean, you just should keep on practicing the way you are, and you should do fine in the exam.
Okay, thank you. Thank you, Dr. Sayan.
Okay. Who is the next candidate?
I'm
Dr. Ruby is
Ruby.
there.
Sorry, I didn't get the name.
Ruby.
Okay, fine. I'll just try to stop this. Just can you, Dr. Kashfa is controlling this.
I want you to somehow stop
Yeah,
it.
I
Because
also desperately want that to happen. Just 1 second. Yeah, okay.
Because I can't unmute.
Yeah, I have
want to
done
mute
that.
myself.
Yeah, I have done that. Wait.
Okay, thank you.
I'll just try to 1 second. This is very irritating, this thing on the net. So you're candidate 3, right?
Yeah.
Okay, so Dr. Ruby, this is your first case. Okay. I've forgotten what case it is. Just let me see. Right. So this patient came with Abdominal pain and discomfort. You okay? I will also. Can you request control or okay? I will give you. Wait.
I can.
Okay. You can scroll.
Yeah. So I'm provided with the CT scan of the abdomen, and I could appreciate there are some calcifications, probably pleural calcifications, and the liver appears unremarkable, no obvious mass. And okay, so in the right side of the colon, I could appreciate there is a fat density lesion, which likely suggests the lipoma. And the rest of the ascending colon also shows thickening and surrounding fat stranding. So there's no evidence of small or large bowel dilatation. And, yeah, especially this, the right colon, yeah, it's especially in this region, it appears to be, it shows circumferential wall thickening. And there are some diverticulosis as well.
Okay.
And so this appears to be an inflamed loop of the bowel. On the right side of the colon, it could be an infective colitis. And the lipoma associated, the colonic lipoma could be an incidental finding. There is no evidence of any
No.
intussusception here.
I wanted to stop scrolling at that particular point first. Just go back to that area.
Okay.
Yes. Now you stop scrolling and you tell me. You said there is a lipoma. What else is happening there?
Okay. I'm not seeing any telescoping of the bowel loop into the adjacent
Are you
wall.
sure
So,
about that?
yeah, that's what I want to say. I want to further confirm this on the coronal images. If
You
this
can
is
do
a,
that. You can do that. There are coronal images. In real exam, there won't be, but here you
okay.
have them.
Okay. Okay, so I'm provided with the coronal images. And yes, on coronal images, I could appreciate there is telescoping of the bowel loop into the adjacent colonic loop. So that confirms the intussusception and with the lead point as the lipoma. And so but however, there's no evidence of the proximal dilatation. So in my routine practice, I'll inform the findings to the referring clinician, and patient needs to be urgently reviewed by the on-call surgical team for further management. And in my routine practice, I'll also change it to the lung window to see any evidence
So
of
what
free air.
intussusception is it?
This is the colocolic.
Are you sure?
Okay. I'll check again. Yes. I'll go back. There is a part of terminal ileum which is also invaginating. So yeah,
So it is?
ileocolic.
What are the lead points for intussusception? What were the lead? I mean, this is a lipoma. That's fine. What are the other lead points that are possible?
Most commonly in the adults, it's used to be the GI malignancies and
Like
other like colonic carcinomas. And other could be other common causes.
Cancer.
Colonic colonic primary cancers or metastasis are also common. And in benign causes, your polyp just...
No, what I'm trying to say, what is the lead point? I mean, malignancy is obviously there, but any other lesions that can be a lead point as well?
Metastasis?
Yeah, other than neoplasia. I mean, see, everything is neoplasia. What I'm trying to say is that any particular lesion or any kind of entities that you can think of?
In the children's, we could think of Mickel's diverticulum.
Okay. In adults, I'm asking in adults only. No problem.
Okay. In adults, other than the tumors.
Other than see, this was a lipoma because this was a fat density lesion, right? So
Yeah.
suppose this is not a fat density lesion, you can see an enhancing lesion. What will you think of? Okay, fine. What is your next step? You will inform the findings to the clinician. How do you think this is going to be managed?
This needs surgical intervention.
Okay. Yeah, I think that's it. I don't have anything more to ask. You told about the complications, I think, right? So I'm not going to dwell on that. Next case. Right.
1 day male, 27-week gestation.
Yes.
Okay. I'm provided with the chest X-ray frontal projection in a neonate. I'm not able to appreciate the humeral epiphysis. So it's a preterm neonate, most likely. And I could appreciate there is the endotracheal tube, which is quite low in position, and seems to be in the right main bronchus. And it should be pulled upward, as well as there is the nasogastric tube, which is quite satisfactory in position, and both lungs appears to be granular and hazy with associated air bronchograms. So that's most likely suggests the respiratory distress syndrome. But
Okay.
There's no evidence of any pneumothorax or pneumomediastinum in this image, no pleural effusion. So in my routine practice, I'll pick up the phone and inform the pediatricians for the malposition endotracheal tube.
Abdominal pain. This image, the image that you're seeing now, and your next case, both are related to each other. So I just wanted to tell you about that. Since in exam you'll get different markable events, it doesn't depend on the number of cases you see, it depends on the number of markable events you see. So this event and the next event are related to each other. I want you to first describe this X-ray.
Okay. So this is the X-ray abdomen frontal projection, and I could appreciate there is the sternotomy sutures in the lower chest, and there is another calcified lesion, which is well defined.
Are you still controlling the screen?
Yes.
Yes. You can just point them out.
Okay, so it's a well-defined calcified.
I cannot see your mouse.
Yeah. Now?
Yes. Tell me. Yeah.
So it's a well-defined calcified lesion, which is probably seen within the gas shadow of the stomach.
Which one is the calcified lesion? The where you're pointing the arrow?
Yes.
Are you sure that's a calcified lesion?
Yeah, that's what I'm going to give the differential. It's projecting, appears to be within the stomach shadow. So it could be that percutaneous endoscopy gastrostomy tube, PEG tube, that is usually given for the drugs or nutrition to the patients.
Right. So what are the common conditions where you can get a PEG tube inserted?
It's usually given for the enteral feeding.
In a patient, I mean, what kind of a patient?
In a patient who's not able to take orally, if he's having oral.
Yeah, that is obvious. What I'm trying to say, what are the conditions where this thing can occur?
This thing can occur. I'm not sure.
I mean, what are the common instances where you need a PEG tube?
Okay. I think if patient is not able to take orally, and then they put the PEG tube for, especially for the drugs.
What are the things that can lead to that kind of a situation?
Okay, I think if there is an esophageal strictures and malignancies which is obstructing the esophagus or proximal.
Apart from malignancy.
Okay, strictures and.
Okay, since the two markable events are related to each other, I will go to the next case for you. Both are not the same patient, since I don't have the same patient images. So both have different patients, but I want you to ignore the history and just see this image.
Okay. So I'm provided with the chest X-ray frontal projection, and I could appreciate there are ill-defined air space opacities are seen within the both lungs, predominantly in the upper and the mid zone, with associated fibrotic or atelectatic band in the right upper zone as well. And the lung volumes are maintained. And there is, I'm looking for any pneumothorax. I have a little doubt on the left side, but I'm not sure. I don't think so. Okay, so no evidence of pleural effusion. And it appears to be the bronchi in the upper zones appears to be thick-walled and dilated. So I'm thinking
Okay, fine.
this is most
I mean, you
likely a
don't have to
bronchiectasis.
describe in that much detail. You just tell me what you think is happening.
I'm thinking it's likely a case of cystic fibrosis.
Okay, fine. So what will you do next?
So I'll review the previous imaging for any interval change and the previous record of the patient if he's a known case, and the ultrasound of the chest as well to look for any other
Ultrasound
abdominal
of the
findings.
chest.
Oh, sorry, abdomen, to see the abdominal manifestations of cystic fibrosis.
What kind of abdominal manifestations are you expecting that can be seen on an ultrasound?
Like liver changes, these patients are also prone to cirrhosis, and pancreatic atrophy and gallstones.
Not very sure what the cost. Okay, fine. So yeah. So how do you diagnose cystic fibrosis in general?
There is a lab test, sweat chloride test, and then I think genetic screening.
So
testing.
can you correlate the previous image with this one?
Okay, so yeah, for the long-term drug infusion, they can put the PEG tube in these patients.
Only drug infusion or other stuff also?
Yeah. Or
Drug
feeding as well.
infusion as in like PEG tubes are not generally for drug infusion. PEG tube is for nutrition.
Enteral feeding, yes.
So cystic fibrosis patients will need PEG tube for G tubes for enteral feeding. They sometimes require that. So I think that's it. Any more question? If I'm forgetting, I'm just trying to recall. So how will you follow up this case, and what are the things that you look out for? If suppose there is a known case, and what are the things that you'll try to see in this case, so that, I mean, what are your I mean, lookabouts? So like where will you look at?
So in the chest, I will look for the other complications, any complication of pneumothorax, pneumomediastin, and
will you do any more imaging?
Chest CT.
And what will you try to see in that CT? Suppose you have a previous image and you have this image. It's a known case of cystic fibrosis. What are you trying to see?
Yeah, generally speaking, nothing much. So
No, not like that. What I'm trying to say is that it's a cystic fibrosis patient, which is already known to you, right? So why are you at all investigating that patient this much? Why are you doing this?
If he's a known patient, then this patient needs the antibiotics for this acute exacerbation, acute infection.
Yeah,
and,
so what are you trying to see in the images?
Correlation with the previous one. Sorry, I couldn't get the question.
No. Yeah, you said antibiotics, right? So cystic fibrosis patients need a regular follow-up. So what do you see in the images in cystic fibrosis? I mean, what are you trying to see whenever you see a patient who's a known case of cystic fibrosis? What are you trying to see? Find out in the images of that patient in the chest.
Any acute infection?
Yes,
acute
that's the thing. You always look for flare-ups. The only reason you are doing all this is because you always look for flare-ups. So there is a reason that the patient undergoes this many tests, because cystic fibrosis will have recurrent infections, and you are trying to see a flare-up. So what is the long-term management for cystic fibrosis? Hello, are you there?
Yes.
Yeah, okay.
Long-term.
What is the definitive treatment for cystic fibrosis? Is there any definitive treatment for cystic fibrosis?
I'm not sure. For pancreatic replacement enzymes.
Pancreatic replacement enzymes.
Because of
not sure it's
atrophy. Yeah.
That is just a manifestation. I was talking about the lung actually. Anyways, okay, not a problem. I will tell that answer later. So it's a screening mammogram, and just wanted to see the images. You can see whichever image. This is a last case. This is a good case, so I want to do it properly.
Okay, so this is the breast tomosynthesis. And
yes, right.
I'm looking at the craniocaudal projection. I'm not able to scroll. Okay, it's tomosynthesis, right?
Yeah, it's a tomosynthesis. Just tell me. Yeah, that's fine.
Okay, so So I'm looking for any evidence of a mass,
Mhm.
which I'm unable to appreciate. Can I look into the
You can
other
see all
side?
the images, whatever images.
Okay. So in the okay, this one is the CC and the left MLO. Actually, in my routine practice, I'll keep them side by side and compare them. Okay. There's a benign
You
looking
just
lymph
describe
node.
the images to me. You don't have to see the lesion at this point of time. Just tell me.
Okay, so breast parenchyma is a mixed fibroglandular and the fatty. And I'm not seeing any evidence of a skin thickening. I'm looking for any mass, which
Okay.
any asymmetry in comparison. No evidence of
In
any
comparison to
enlarged
what?
in comparison to the other breast. Which
Can you see the other breast?
no.
You can see the other breast.
I think these are all left.
Yeah, these are all left. That's what I'm
Yeah.
saying.
Okay.
So you
So
cannot see the
there,
other breast.
yeah. So there is a small irregular ill-defined lesion is seen in the central part of the posterior aspect of the breast,
Okay.
and which shows some speculated margins. And I'm not able to appreciate any microcalcifications within. And there's no significant enlarged lymph nodes. So it's
So are you
suspicious.
supposed to comment on the lymph nodes on this image?
No, I've seen the axilla.
Okay.
I saw a
Okay.
benign looking, yeah. I saw one benign
Right.
looking lymph node.
So what are the things that you look for in a mammogram when you're describing a lesion?
The margins, irregular, any speculations surrounding architectural distortion, adjacent skin thickening, nipple retraction, lymphadenopathy, microcalcifications, the pattern of microcalcification, pleomorphism or clustered.
And based on that, what will you do? Based on
Uh,
those things?
Yeah, if there is, I'm suspicious of any lesion, I'll further do the ultrasound for further confirmation. And
No,
otherwise,
yeah, that is fine. For reporting a mammogram, what will you do?
okay,
I mean, what will you give?
I'll suggest the patient referral to the one-stop breast
No,
clinic.
no. What I'm trying to say is, what is your impression of the mammogram?
Okay, so depending on that, I'll give the Virods, whether it is
So in the
M.
UK, you use
M, yeah.
yes. So this is M what according to you?
M4. It's suspicious.
Okay.
Yeah.
So what will you do next in ideal scenario?
Ultrasound.
Yes, there is no ultrasound. I don't have any ultrasound with me. So what will you see on the ultrasound? What are the markers?
If it's hypoechoic, it's taller than wider. And if it's the, again, irregular margins and posterior acoustic shadowing and enlarged.
Those are the suspicious features.
Okay.
Yeah, you're talking about the pointers towards the malignancy, right?
Yeah.
Okay. Apart from that lesion, what else will you see on ultrasound?
The opposite breast as well. Lymph
Yeah,
nodes.
you can
axilla.
just tell me like what you do in usual practice. This is just a normal discussion.
Okay. So as well as the axillary lymphadenopathy, if there is loss of fatty hilum in the axillary regions, and I'll do the other breast as well. And then I'll put the, yeah.
And then you will?
Yeah, and then correlate both together, the mammo ultrasound
Right.
findings.
So in the same breast, what will you see?
In
Is
this
there
case,
anything that you look for? Is there anything that you see on the same breast where the lesion is before you go to the other breast?
sorry, I couldn't get the question.
No, you're seeing a lesion in a breast in your usual practice. You have described the lesion, it is U4 or U5. Do you see anything else respect to the lesion in the same breast? Or you just see that one lesion and you go to the lymph node?
No, we will assess the full breast for any satellite lesions. Any other?
Right. And any distance that you measure in your practice for that?
Yeah, distance from the nipple as well.
Right.
Oh,
What are the markers? You said loss of fatty hilum for a node. Apart from loss of fatty hilum, what are the other things that are suspicious when it comes to a node?
if it's hypoechoic, if the diameter
Nodes are
anteroposterior,
always hypoechoic.
okay,
That
if
is loss
the
of fatty hilum you're saying. Yeah, that point is fine. Other than that,
and if the diameter is more than 1.5 centimeters anteroposterior,
what diameter you're talking
and
about?
anteroposterior, not
In
in
an,
the
in an
not in the
axillary lymph node, do you measure the anteroposterior diameter on an ultrasound?
yeah, I mean not in the transverse, the width, but along.
No, what I'm trying to say, what are the markers of a suspicious lymph node in the axilla?
The most significant is the loss of fatty hilum, and then the size,
What size? That's what I'm asking you.
1.5 centimeters.
What is which thing is 1.5 centimeter? You're talking about the short axis diameter.
Yes, in the
Okay.
short axis diameter.
Okay. Anything else? Any other markers? Okay, fine.
No.
So this patient, the density is dense. It's a dense breast, right? So the patient went for an MRI mammo. You can scroll.
Okay. These are the MRI images of the breast, even contrast enhanced images, and I could appreciate the lesion abnormal signal intensity in the left breast posteriorly, which shows the irregular spiculated margins.
You don't
And
have to
it's,
describe it once again for me because there is no point in that. You just tell me what are the things you see on an MRI breast.
so again, I look into the any other lesion, especially,
Okay.
and enhancement of the lesion. And
What
if
kind of
it's,
enhancement?
I mean, if it's enhancing or not. And
Even
not
the
a,
glandular tissue will enhance. What
yeah,
is that? Yeah, so how will you differentiate it from a lesion versus a glandular tissue?
I'll compare it with the T1 and T2 because the malignancies used to be hypointense on T2.
No. Just tell me about the enhancement.
Okay. It's hyper enhancing, and I don't know.
Is anything about the kinetics that you will see?
Yes, we will assess the curves as well. If
What
it's
kind
the
of curves are you expecting?
type 3 curve in the
If
malignant
it's a
lesions.
malignancy. So tell me, I mean, which is the, assuming this is a cancer, why do you think the patient underwent an MRI?
To look for the synchronous
Yes.
lesions.
What type of cancer usually presents with synchronous lesions?
I'm not 100% sure, but maybe lobular.
Yes. So this is a lobular cancer. So you did very well, I think. So you don't get an MRI mammo in most probability. I just got this case and I was telling what I used to do in my institute. I was just discussing those points. So lobular cancer, you usually do a MRI because it's a very common thing for involving the contralateral breast. Other things that you see are the kinetic pattern. It's type 1, type 2 versus type 3 curve that you told. You see any non-mass enhancement. Okay. If there is any non-mass enhancement which you cannot correlate on the T1, T2 images, then you have to be suspicious about that area. And if you cannot localize the area in ultrasound, you may have to go for sampling MR guided. Okay, but that's okay. Those things won't come probably in your exam. What will come though is this. So in an axillary lymph node, never say the short axis diameter. That is not at all important. What is important is the cortical thickness. Okay. So in axilla, when we see whether a lymph node is suspicious or not, we don't see the short axis diameter. We see the cortical thickness of the node. If it is more than 3 mm or 2 to 3 mm, then that is suspicious. Another thing, as you said, is loss of fatty hilum. Another thing is the shape of the node. If it is a rounded node, okay, a very small node, which is a rounded node, you have to sample that node. Okay. So it doesn't, the size, even more than size, the shape is very important when it comes to a node. Okay.
Okay.
The concept of short axis diameter is a backdated concept. Don't go into that. We don't see a short axis diameter of the axial lymph node when we are thinking it is suspicious or not. Okay. Should keep that in mind. Next things are probably, I didn't ask you those things, but I already asked someone before that you sample the lesion, you have to say breast MDT. Okay, whenever you sample a lesion in the UK, that lesion goes to the breast MDT, because you are screening this patient, you are sampling this patient, and the surgeon needs to know what is going on. So you have to take this to the MDT. Okay. Next I come to your previous case. This you did fine. This was cystic fibrosis, and I showed you the pec tube in the previous image. So pec tube is seen in cystic fibrosis, and yeah, you have to see for flare-ups, as I told you. Other things are, I think you did great on the other things. Nothing much to say on that. Abdominal pain. Yeah. Oh, this was that same case. I'm not going to discuss this. This I moved on because I just wanted to see the ET tube placement. ET tube was malpositioned. You told it correctly, and that's it. So that's all I wanted you to see. That's why I rushed through this case. And this is which case? This was your first case, I think. Yeah, this was intersusception. So yeah, I was looking for polyps. Okay, so polyps are a very common cause of intersusception. So whenever you see intersusception, you have to think about polyps as a possibility. Other than polyps, any submucosal lesion, as you told, like metastasis or maybe a GIST, small GIST, those kind of things can also cause intersusception. But polyps, you should keep in mind, if you are seeing multiple polyps, you have to rule out syndromic association, familial adenomatous polyposis, and such things. Look at the family history of the patient. Okay, so never miss polyps. This was a lipoma. Obviously, there was some diverticuli, but that's okay. I think this was the last case. I mean, the first case. So you did well. There's not much to add on that. Just like you can just go to your routine practice and you'll be fine. Okay.
Thank you.
Okay. So, hello.
Hi, Dr. Sayan. So do we have Jarvis with us?
I
I
don't
I think
sure.
he's not
He's
there. So
absconding, isn't he?
may I ask Dr. Salman to join us?
Yeah, whoever is free can join. I don't know.
Um, yeah, Dr. Sid, I'm here.
Is this
So,
Dr.
so
Salman?
this is who?
Dr. Salman.
Okay, Dr. Salman. So, shall we start?
Yes.
So, this is a 40-year-old female with a low backache under evaluation. You have been given MRI, LS spine. I will give you the control. Okay. Salman. Okay.
I've
Yeah,
requested
you
it.
can scroll.
Is there a specific subset that you would want me to look at
No,
first,
no,
or
you
I can
just
go?
take whichever image you want.
All right. So this is MRI lumbar spine of a 40-year-old person being evaluated for backache. So I'm scrolling through these images, which are fat saturated T2 images, and I can see that the spinal cord suddenly it appears that it is splitting into two, and then it caudally deviates towards the right, and then further caudally I can see a few nerve roots that are pushed towards the periphery. Um, I would like to look at the T2
Yeah, you can see
images
whichever
as well.
image you.
So looking at the T2 weighted images, all right. So there is this T2 hypointense lesion in the region of the which is abutting the cauda equina at the T12L1 level. It has a low signal on T2 weighted images. On T1 images, it is iso intense to the cord parenchyma. On the post-IV contrast images, this shows significant evid enhancement. seeing the post-IV contrast axial images, this lesion appears to be, to begin with, it appears to be intradural and intradural and extramedullary. Since it has, since it appears to have, a lesion that is predominantly intradural, extramedullary, and has caused mass effect upon the spinal cord in the region of the corda coina, enhancing. I would consider meningioma, nerve sheath tumors.
Right.
Meningioma and nerve sheath tumors. Could have considered hemorrhage if the signal was going with
that's
that,
fine. That's fine. What are the nerve sheath tumors that you're thinking of?
I'm thinking of schwannoma.
Okay. What will you do?
I would call the referring clinician and inform him about the findings. The neurosurgeon needs to be on board.
No. Before you involve the clinical team, what are the things, other things you will see?
I would look at I would review the other images as well to see if there are any further lesions. I would also look at the neural
Other
foramina.
images of which part of the body?
Firstly, all the images of the same scan. Then I would also like to look at the neural foramina if they are expanded. If there are any additional lesions.
Additional lesions where? That's what I'm asking.
Additional lesions within the neural foramina.
That's fine. I'm just saying which part, like neural foramina of what? You're already
spine.
seeing the lumbosacral spine, right?
Yeah. The entire images of the lumbar spine that are available. And also, and if I see multiple lesions, I would also like to look at the thoracic spine.
You can just see the whole spine, right?
Yeah.
Okay. Apart from the whole spine?
I would also like to look at the soft tissues, if there are any neurofibromas.
Where? I am saying that you're seeing the spine, right? When you're seeing anything in the spine, is there any other part of the body which you want to screen?
Yes, looking at a case where if I might see multiple neurofibromas, I would want to image the brain as well. The brain imaging is important to look for any further lesions.
Okay. So what are the thing is neurofibroma you told? Anything else?
You're talking about the differential of this very lesion?
No. I mean, what are the other kinds of lesions that you can expect in the brain in a patient who has this kind of lesions in the spine?
One can see, unidentified bright objects, bright spots in the brain parenchyma. With NF1, one can see, sphenoid bone dysplasias, sphenoid wing dysplasias.
Schwannomas are common in which type of neurofibromatosis?
Sorry, I mixed up the two. So
you are talking about NF1, right?
Yeah, schwannomas are more common in NF2.
So in NF2, what are the things?
So in brain, I would be looking for acoustic neuromas, and bilateral acoustic neuromas are diagnostic.
Bilateral what? I couldn't hear that part.
Bilateral acoustic neuromas are diagnostic
acoustic neuromas, yes,
NF2.
right.
Multiple intracranial, meningiomas, schwannomas, and epidermolysis.
Okay, fine. So suppose, I mean, maybe this case was not. So if it turns out to be NF2, what will you advise the clinician? What will you advise the patient?
The family of the patient needs to be,
exactly.
screened for NF2. The as we've already discussed, the brain needs to be imaged.
Okay, so yeah, that you
the-
told, that is correct. Then so basically, yeah, that's fine. And then is there anything that you like to discuss, I mean, want to tell the clinician, or anything in particular you want regarding the follow-up?
Well, not in particular that I can remember for NF2 follow-up.
Okay, so overall, what will be your next step? I mean, you have scanned the CNS and the spine, and then
Yeah.
next, what will you do?
Inform the clinician and
And
discuss the case discuss the case in neurosurgical entity.
No.
Neurology and neurosurgical entity.
okay, this is your next case. So the patient came with a leg pain.
This is a radiograph, tibia, right tibia and fibula, frontal and lateral projection of a 6-year-old male that shows accentuated sclerosis in the tibial metaphysis that is also evident on the lateral view. There is a slight, depression in the lateral cortex at this point. The bone is not expanded. The lesion has a relatively wide zone of transition. There are no calcifications. There are no fractures, no obvious periosteal reaction. The rest of the bones and soft tissues are unremarkable.
So what do you think it is? What is the age of the patient?
So in a 6-year patient with a metaphyseal lesion having a wide zone of transition, I would be concerned about a few entities, Ewing sarcoma, osteomyelitis to begin with. The age is not
Why
very...
Ewing sarcoma to begin with?
Because it has a wide zone of transition. The patient is a young person.
What is the location of Ewing sarcoma usually?
Yes, the location is not typical. It is usually metadiaphyseal. This lesion is more of a proximal diaphysis, close to the physis.
Is this a diaphyseal lesion?
Well, it is
I mean,
just...
Yeah, tell me.
Yeah, so it is just inferior to the growth plate. So it is
The growth plate is
metaphyseal.
demarcating what from what?
The epiphysis from the metaphysis.
From the metaphysis, right?
Yeah, yeah.
So this is arising from?
So this is a metaphyseal lesion predominantly.
Yes. So what are your duties?
So since it is more cortical based, and there is accentuated sclerosis as well, osteoidostoma can also be one possibility. Although the patient
In
is
an
still a bit young.
osteoidostoma, but you just now said it is an aggressive looking lesion, right?
Yeah, though even in osteoidostoma, the sclerosis can be widespread and can have wide zone of transition, but the age is younger for that. So osteomyelitis and can be one possibility.
Other than that? Okay, what will you do next?
So I will inform the referring physician.
No, don't. I mean, no, not that. I mean, imaging.
We can do an MRI to
What will you want to see on the MRI?
The exact extent of involvement, if there's any soft tissue involvement.
And I mean, yeah, that's fine. So will MRI help in the diagnostic part, apart from knowing the extent? So what do you think will help you in knowing this lesion better?
An MRI would have helped, I think, but
MRI helps in what? MRI helps in the extent of the lesion, as you told, right? The neurovascular bundle, the soft tissue involvement, skip lesions, and METs, right?
Yeah.
What I'm saying is anything that will help in the primary characterization of this lesion.
Well, for that MRI, might not be very helpful. Well,
So when you are describing a lesion, what are the things that you usually want to see? What are the, I mean, what are the things that you like to see? What are the points that you like to consider in an X-ray? One you told is the zone of transition. Next you told is the location of the lesion. Fine. Then after that?
Yeah. Calcifications or not, the location of the lesion, age of the patient, surrounding soft tissues, cortical break, fracture, periosteal reaction.
Calcification you told, right?
Yeah.
You told one point as calcification, right?
Yeah.
So what does that mean? What are you trying to see? Well, like calcification is a subpart of what broader category?
Mostly malignant etiologies.
No, not that.
Yeah.
I'm saying that calcification falls under which characterization? I am not asking what is calcification associated with. I am saying in your descriptive terminology, you're describing calcification as a part of which property of the lesion?
So whether it is a bone forming lesion or
yes, you're trying to see the matrix, right?
Yeah, matrix.
So what is the modality that helps you see in the matrix?
Well, CT can show the ring and arc calcifications in a better way.
CT is the modality of choice for the matrix. It need not be calcification. For any matrix, you have to see the CT. Okay, now you can describe.
So the CT scan of the same patient. I'm not being able to scroll actually.
No, it's a spot image. You cannot scroll.
Okay. So this is an axial spot image of the same patient from taken through the proximal tibia where the lesion is. So the lesion shows a predominantly osteoid matrix. I cannot see any. There are a few lesions.
You think it is?
It's a predominantly osteoid matrix. Although there are
so what is it? What are the things which have osteoid matrix?
Well, if I try to enumerate all of them, osteosarcoma, for which the patient is quite young.
What does that mean? Or is the patient quite young means? What is the age for osteosarcoma?
Well, this is a 6-year-old patient. I would have expected it to be a 15 to 30 years age bracket.
Is there any lower age limit for osteosarcoma?
I don't exactly remember, but it generally,
generally happens in a higher age group, maybe towards the 20s. But considering is age the foremost thing that you will consider, considering still a young patient and the location and everything else in the matrix also?
No, not really.
Is the age sufficient to rule out osteosarcoma?
It is not. But
what will you do next?
Well, I will discuss the case with the referring physician. The case needs to be discussed in.
From your end, what will you do before you discuss?
Well, a bone scan and to see osseous metastasis and a CT chest abdomen pelvis for staging.
I think they have done some nuclear image. Let's see. Yeah.
A bone scan of the same patient shows focal uptake in the part of the lesion that we have discussed already. I cannot see any further metastatic lesions. Symmetric uptake in the shoulder joints, sternoclavicular joints, and the rest of the joints. I cannot appreciate any focal metastatic uptake. In the rest.
Fine. So this is just for METs. Now we have the MRI also. Yeah. And these are also probably just still images. So there is nothing extra. So what are the, I just want you to tell me what are the things that you see on an MRI normally? What are the things that you try to see? I already told you once, but I just wanted to repeat them from you.
Yes. So the extent of the disease, the local extent of the disease.
Okay.
the involvement of the neurovascular bundles,
Okay.
the surrounding soft tissues.
Okay.
Uh,
Anything else? Anything that can help you in the surgery?
well, we've talked about the neurovascular bundles, the extent of the
Yeah,
disease.
apart from the things that we have already talked about.
Mm,
Anything that you should measure in a lesion like this? Anything, any measurement? I mean, if you're reporting this case, you measure the neurovascular bundle, you measure whatever surrounding soft tissue and all those things. Anything else that else you'd like to mention in the report?
the relation of the lesion to the growth plate. That is one
Which
thing.
growth plate? The proximal, the knee, or the ankle?
Obviously, the growth plate that the lesion is closer to, whether it has involved that or not.
Okay. Fine. I think that's
Um,
enough for. I mean, that's enough for the management part. I think that's it. So this is your next case. So this is a young boy who has come with chest discomfort.
So chest radiograph frontal projection of a young patient presenting with chest discomfort that shows a large opacity occupying the a greater part of the left hemithorax, the upper, mid, and lower zones. The overlying left second and third ribs are deformed and partly deficient. The rest of the ribs are unremarkable. The left CP angle is obscured. There is no significant mediastinal shift.
Okay.
I cannot see the I cannot see the diaphragm very clearly. The left hemidiaphragm very clearly. The rest of the bones, right lung, right CP angle, and the soft tissues are unremarkable. In a young patient presenting with discomfort and with this large opacity in the left hemithorax, I would, discuss the case with the clinician whether the history is acute.
Don't go with the discussion. What will you see from your end first?
In a patient with deformed ribs, I would think of any post-surgical changes.
There is no history of surgery.
So if there's no history of surgery, I will, think about any history of trauma.
There is no trauma.
All right. In that case, it can the differential of the findings will include a large left-sided pleural effusion, hemothorax.
So any other things that you want to do when you see this image? Is there anything else that you want to do? I mean, before you comment on the etiology. Anything that you like to consider?
You mean further imaging?
No, I don't mean anything. I'm asking you.
I would like to see the exact extent and the
yeah, that to whatever you have seen. What I'm saying is that apart from this image, is there anything that you wish to know or you wish to do before I can come to a better conclusion before going to another investigation? I'm saying with whatever tools you have or whatever resources are available to you, would you like to do anything if you have a PACS, suppose?
We'll like to compare with the previous imaging to see if this thing was present there in the previous images as well, and look for any change
so then the clinician tells you that I mean there was an image from say 1 or 2 months ago, and it was I mean there was still some lesion, but it has probably increased in size now.
that depends that if how much size increase are we talking about. If over a period of 1 month it has suddenly increased in size, then I would think of a development of a pleural effusion that has developed in interval so rapidly.
In a pleural effusion, are you expecting rib changes?
No, I will not.
Is there anything else on this image that you can see?
There's a left approach central line that has a step in the right atrium.
So what do you think? Why has that been done?
Well, it not exactly is a PIC line or a portacath, which would make me think that this has been placed for chemotherapy infusion.
No, you can go on. I'm just listening to you.
Yeah, that is one thing. Does not appear to be a dialysis catheter.
Does not appear to be a what?
Dialysis catheter.
No, this is a central line only. No, I'm just
Yeah.
asking you, what are the things that can, what do you think has happened to the patient?
Well,
okay, you can ignore the central line. This is just an additional point. So you said pleural effusion. So the patient is, if the pleural effusion was there, did you expect rib changes?
No, just with the pleural effusion, I wouldn't. But
so what are the other DDs? You have ruled out pleural effusion. That means, right, yourself.
Yeah.
Yeah. So we can move to the next DD.
I was trying to say that if in a rapidly developing pleural effusion, one should think of an underlying neoplasia or metastasis.
Okay. Yeah. Right. So what will you do now?
I would consider a chest wall lesion,
okay,
or a pulmonary lesion. And
yes. So how will you characterize those things?
I would go for a post-contrast CT chest for further delineation.
Okay, you can scroll.
Okay, so a few limited images from post-IV contrast CT chest that show a heterogeneous left-sided chest wall lesion.
Okay.
That has a heterogeneous appearance, heterogeneous post-IV contrast enhancement, and is eroding the overlying ribs. So
okay.
the different, in addition, there is also suspicious bone lesion as well, but I would need a bone window to confirm that.
Okay.
So
what are your DDs?
So this can be a primary chest wall mass lesion.
Okay.
It can be, yes, it can be a metastatic lesion.
Okay, so what are the primary? Okay, then yeah, you want to add more?
Yeah, so as far as the primary lesions are concerned, mesothelioma.
In a young child, I mean not a young child, but in a young person.
But yes, I was just talking about the DD, but in this patient it does not apply.
You said chest wall, right? So what do you think can arise from chest wall?
A rib lesion, like an Askin tumor.
Any other chest wall lesion that you can think of?
Pardon, sorry.
Any other chest wall lesion that you can think of?
Other than the Askin tumors and Ewing's,
Other than the?
So I mentioned Askin tumor.
You have already mentioned Askin's tumor. I was not able to hear that. I was not able to hear that. Fine. So how will you take this case forward? You can stop scrolling. There is nothing you can see more on these images.
So I'll inform the findings to the referring clinician. The case needs to be discussed in a tumor board MDT. A tissue sampling needs to be arranged and the case needs to be
Where
discussed
will you
for.
sample this lesion from? Tell me the area. And which gun will you use?
An 18 gauge needle can be used to do a core biopsy of this lesion. It can be accessed with an ultrasound guided approach.
In a chest, do you think an ultrasound guided approach is the right
This lesion,
approach?
I would have, gone for a CT guided approach, but this lesion is very large. It is just, sitting adjacent to the abdominal wall, and
So when you are sampling a lesion like this, what are you looking for? What are the things that you're looking for when you're sampling? Which area you're targeting basically?
a solid area, which would give
How will you assess that
a
on an
high.
ultrasound?
So an ultrasound, a fluid area would be in a more heterogeneous.
No,
type of
I mean, see, there is no fluid area in this lesion, right? So everything is almost like a solid thing only. What is the exact thing that you're looking at when you're sampling it?
While sampling a lesion in ultrasound guidance, you are looking for the part that is most solid looking.
No, yeah, I totally get your point. In this lesion, do you think there is any fluid component in this lesion?
A few parts posteriorly, they seem to be of
That
fluid density.
obviously you can ignore. I mean, the rest of the lesion.
Well, mostly the lesion is solid.
Exactly. So in a solid lesion, which is almost entirely solid, which area do you target for sampling?
A more central area. You wouldn't want to go much deeper because with the fear of causing lung injury.
Much deeper, and, as in?
Well, I'm talking about the depth from the skin.
You can show me on the screen.
We're talking about ultrasound guidance. So under ultrasound guidance, one would prefer a biopsy to be taken from the central part of the lesion.
So you want to go to that area under ultrasound guide. I mean, why are you choosing that area? Okay, I think these are just additional questions. I mean, these are all real exam questions, obviously. But it's okay. I mean, may not be the benchmark for passing the case, just additional questions. So we'll go to the next case. This is a patient who presents with vomiting. You can scroll the images.
This is a CT of a 65-year female who has presented with abdominal distension. So I'm scrolling craniocaudally, and the stomach is mildly distended. The small bowel is moderately distended. And while scrolling, I'm also looking at the vasculature. So the celiac and superior mesenteric arteries appear to be patent. Superior mesenteric vein also appears to be patent. The small bowel is dilated, and I will now try to look for a point of transition. So I'm going down.
Go down.
Yeah. So I've seen So I've seen a small bowel loop that is extending into the right inguinal canal, so I'm just trying to make out whether this is an inguinal hernia or femoral hernia.
Okay.
So this is.
So how do you do that?
The lesions that are more medial to the pubic tubercle, are inguinal hernias, and the ones that are lateral to it
Yes.
and more adjacent to the femoral vessels are
Yes.
more likely to be femoral hernias.
So this is which one?
This appears to be femoral, since this is
Right.
very closely.
So also, can you sum up the case for me?
Femoral hernia, an obstructive femoral hernia that is causing a small bowel dilatation.
What are the
From
things
the
that you would
images,
like to see?
so I would like to see any signs of bowel perforation.
Okay.
Or for the hernia to be exact, I would assess if there is any fat stranding surrounding the hernia, if the hernia is incarcerated or strangulated, which would be a sinister sign.
Okay, that's fine.
Yeah.
So how will you take this case forward?
Immediately call the emergency physician and take the surgical team on board.
You can stop scrolling. Don't scroll. Don't scroll.
The small bowel obstruction has to be relieved urgently, and the patient has to be taken care of by the surgical team.
This is your last case. Diffuse tenderness, raised white cell count. You can scroll.
Post-IV contrast CT abdomen pelvis of a 70-year person was presented with abdominal distension, tachycardia, and pain. So there is a bland thrombus within the right anterior and posterior portal veins extending into the superior mesenteric vein, partly distending it. Scrolling down further, it has extended into its cranial branches, which are distended. There's marks surrounding the root of mesentery edema, and I can also see a few small bubble loops that are dilated in the left upper quadrant with non-enhancing bubble walls. Although I cannot see any, pneumatosis. So I'll finish this. Try and finish the scrolling. So far, I haven't seen any pneumatosis coli, diverticulosis of the large bowel.
So far, you have not seen any.
Pneumatosis intestinalis.
And what about diverticulosis? What did you say?
There are a few diverticuli along the sigmoid colon.
Okay.
But this is diverticulosis. I cannot see any definite evidence of diverticulitis.
Okay,
yes.
carry on.
Yes. There's myelositis as well. Incidental findings of bilateral category 1 renal cysts, the superior mesenteric artery and vein appear patent. So this is extensive thrombosis of the portal vein, superior mesenteric vein and its branches, causing acute proximal small bowel ischemia. The findings need to be urgently conveyed to the emergency team and the surgical team because this needs immediate management. And since the bowel is ischemic, and this is impending for gangrene and perforation.
Okay. What do you think is the management? Don't scroll.
Okay. For the bowel that is not enhancing, it should be managed surgically.
I'm sorry, I didn't get that part.
The part of the bowel that is not enhancing, that means that it is ischemic and it is going on to become a dead tissue. So it has to be managed surgically.
Like, what will you do?
So the surgeon needs to go in and remove the dead part.
Do you think that when you tell the surgeon that this patient has a portal vein thrombosis, the first thing that needs to be done is the patient needs to be taken to the OT?
The gastroenterology also need to be on board, and the patient needs to be anticoagulated for the.
You just start thrombolytics. You won't do anything else.
Yeah. All right. Yeah.
Okay. So yeah, I mean, you're fine. I mean that's your last case. It was fine. I mean, you just need to probably look at the management part a bit more, because we tend to underestimate the management part in the exam. But in reality, the management part is asked quite a bit, because in this case, the portal vein thrombosis is like is very obvious. Okay, they are going to stress more on the management, and you have to talk about IV thrombolytics in the first go only. They usually they won't. I mean, it's not no reason to open up the patient right now. You just try to thrombolize the patient so that you can save whatever is there, and hopefully the other parts will also regain perfusion. If you open up the patient, you cannot do anything. You're not going to resect that large amount of bowel and anastomose the rest. Then the patient will have a lot of complications developing from that. Okay, so surgery is not the first option here. Okay, next, your previous case. This was your previous case, right? Yeah, this was obstruction. You told fine, there is no problem. It was femoral hernia causing obstruction. That was perfect. This was this case. This you did okay. It was Askins tumor. Okay, when you're seeing rib destruction and all, you just you told correctly, chest wall lesion, pleural effusion. Yeah, if it's associated with the malignancy, is fine. Otherwise, it won't. There won't be pleural effusion causing destructive changes and all. So you have to keep that in mind. And about the sampling, sorry, I didn't show you the MRI there because it was not necessary. So sampling in a lung lesion, chest wall lesion, which is going into the lungs, the only thing, the main thing that you see is the enhancement. Okay, because this is predominantly a solid lesion. You try to sample it from an area which is most viable, so that the biopsy does not come as repeat. Can you hear me?
Yeah.
So ultrasound guided biopsy for a lung lesion is not that common. It can be done, as you told, but there is a very high risk of pneumothorax as you'll go in blind with ultrasound probe, and you'll have to target a peripheral lesion. Ultrasound, you can never target a central lesion. Okay, never say a central lesion. First of all, don't say ultrasound in a lesion which is involving the lung, because I have hardly done myself, or I've hardly seen people do ultrasound guided lung biopsy. This is a very rare thing to do. You won't do it because you are scared of injuring the vessels, you're scared of injuring the fissures. In a lung biopsy, you don't go through the fissures also. So you will do a CT guided biopsy, and a CT guided biopsy, the main thing that you will see in such a large lesion which is so much necrotic is the enhancement. So in such a case where there is there is some areas, and probably this area which is still enhancing, you'll try to target this area instead of this area which is not at all enhancing. Okay, so you're just trying to get a viable tissue, that's all. Next, before this case was, so this case I just wanted you to tell osteosarcoma, because it was an osseous matrix lesion. It was in the metaphyseal location. It was showing up on the bone scan. Yeah, age may be a bit on the lesser side, but I don't know. Did I mention anything particular? Okay, I told 6 years. Yeah, 6 years is a bit less for osteos, but the thing is that, see, the other features are going in favor of osteosarcoma, because Evans will be a diaphyseal lesion with a lamellated periosteal reaction and all. And I don't think, based on one particular categorization, you can rule out osteosarcoma, especially the matrix is so much osseous, as you told. Rest of the things are fine. You just tell staging CT, chest, abdomen, pelvis, bone scan for bone-to-bone mets, and then finally discussion. One more thing. You will tell that you refer the case to sarcoma MDT, to regional bone tumor center. Okay. For all bone lesions, you will say it's a regional bone tumor referral unit. You will sample the lesion there only. You won't yourself sample the lesion. It has to be sampled at the regional bone tumor center under the supervision of the specialist. And the surgeon also needs to know. I asked you about the distance from which joint. You have to see both joints. Okay. We are trying to see whether you can preserve the knee or not. Okay. If it is involving the knee, we have to go for an above the knee amputation. If the knee is spared, we go for a below the knee amputation. It's a young patient. We're trying to preserve as much of the leg as possible. If you're amputating the patient, the surgeon needs to know from which side you're going in to avoid biopsy tract spread. Okay. These are all the technical aspects of management, which may not be asked, but it may be asked if the examiner is trying to mess with you. This was your last case, rather your first case. So this was fine. This was just a schwannoma. All I wanted you to tell was the neurogenic tumors, what are the possible differentials, what are the systemic manifestations, syndromic associations and all. You told fine, this can be as NF2. NF2, you have to tell about family history and management. Those things are fine. And not much to say on this, I suppose. You told schwannoma correctly, and now shit tumor is definitely, the other types are DDs. And the enhancement goes in favor of schwannoma. T2 hypointensity is also in favor of schwannoma. I think that's it. I think you did fine, just the management part. You're sitting in the exam in June?
Yeah.
Okay, so I think you just need to just do a bit of the management part. Rest of the things are fine. Okay.
Thank you. Thank you.
Yeah, I think that was the last candidate, isn't it?
Yeah, that was the last one we had. Yeah. Thank you so
Okay,
much,
okay.
Dr. Sayan.
Okay,
It was
same,
wonderful
my
having
pleasure.
you. Thanks for your
Yes, yes.
cases, and also
No
you
issues.
you discussed all the relevant points. It was quite helpful.
Thank you, my pleasure.
Yeah, thank you, everybody.
Thank you very much, Dr. Sayan. It was a pleasure.
Yes, yes.
And it's
No
very
problem.
late in India. Have a good rest.
Yeah, yeah.
Bye.
Yes. Okay. Good night. Good night,
Good night.
everyone. Yeah, yeah. Bye bye. Bye bye.